the schedule is a bit packed, and so our next speaker will be Associate Professor Dr. Diana. She's our senior lecturer who is a hematologist, and her CV is very remarkable and very long that I cannot complete within one breath. So without further ado, I'd like to invite Dr. Associate Professor Dr. Diana to present her topic. Dr. Diana.
Can you all hear me? Am I clear?
Yes.
Okay. Is my screen visible? My slides visible?
Yeah, very clear.
Okay. All right. Just going to talk about how to run the INR clinic, okay, especially for the district setting. Okay, so the outline of the topics include the pre-initiation phase of warfarin, which what you need to know is who needs warfarin and the warfarin in the special groups, and how do I counsel and educate patients for warfarin, and how do I assess them for the risk of bleeding, and what are the other adverse effects of warfarin, and also baseline testing required before starting warfarin. Post initiation of warfarin, what are the dosing as well as monitoring of the warfarin, and in terms of erratics INRs, what should you do, as well as when you need to reverse and stop in case of elective pre-op as well as bleedings, and when you should consider use of NOAX or DOAX. Okay. So who needs warfarin? So these are the patients who need warfarin. Basically, they are cardiac patients with underlying atrial fibrillation, prosthetic heart valve, as well as left ventricle thrombus. Okay, there are other patients which are including hemato patients or oncology patients, orthopedic, respiratory patients, neuro patients, etc. So these groups are usually those having a deep vein thrombosis, which may be typical sites or sometimes atypical sites. Okay, and they are also those with arterial thrombosis, and they may have pulmonary embolism or underlying antiphospholipid syndrome or other thrombophilic disorder. Okay, so in special groups, who are they? Okay, so the first one is pregnancy. Okay, so in pregnancy, we need to be cautious. Okay, especially antenatal, the first trimester, their warfarin is contraindicated because they are at risk of causing embryopathy. Okay, during the first trimester, as well as CNS abnormalities, and the fetal will be at risk also of bleeding as well as a miscarriage. Okay, and intrapartum, especially third trimester, they are also contraindicated because they are at higher risk of causing perinatal bleeding. Okay, this is because the warfarin can cross the placenta. Okay, so basically the main take-home message for this is you need to avoid warfarin, especially for the first and the third trimester. Okay, so usually it's low molecular weight heparin is preferred during pregnancy. Okay, for elderly, we have to be cautious in this group of patients because they are at higher risk of fall, they have cognitive decline, and they have more comorbids, and they may be also on multiple drugs. So this actually can affect the risk of bleeding as well as compliance. Okay, another group are those regardless of age, are those having any comorbids, in particular those with active bleeding. So if they have history of active bleeding or any risk of bleeding, we need to either stop or be cautious, okay, while they are on this drug. So how to counsel the patients for warfarin? So first you need to introduce the name of the warfarin. The name of the warfarin, the patient really need to know, okay, because it's important for them when they come to see a doctor or a family or any dentist or if they are on this blood thinning drug, they need to know how to inform the name of the medication that they are on, okay, and they need to know what dose they are taking, and they should know that they should take the medication at a fixed timing each day. Example, between 5 to 7 p.m., same time every single day, right? And the duration that the patients need to take. Okay, so the duration would depends on the underlying diagnosis as well as the underlying, if it's DVT, is depend on the underlying provoking factor, whether they're provoked or unprovoked, and whether the risk factor is persistent or not, okay, or whether there are underlying malignant conditions associated with it or not, okay, and whether the risk factor for the thrombosis is a major risk or a minor risk. So there are many factors to consider, okay. And you need to explain also how, what's the indication for the warfarin in this patient. So basically, in a layman term, you should tell them is to prevent clot. Okay, to prevent clot, because if they have clot, they can have symptoms. They can, if it's in the lung, they can affect their lung function. If it's in the brain, they can causing them to have neurological deficits. All right. So, and how it works basically is counteract. In the layman, you say can counteract the action of vitamin K. It's important to know that because there are foods with vitamin K that they need to control, right? So it counteracts the vitamin K, which actually is important for clotting. And what are the benefit and risks for the treatment? So basically, I will go through it in another slides, okay, because it's a bit more lengthy. And they also need to understand that warfarin has interaction with medication, supplements, and diet. So therefore, they need to also know that whenever they're on new medications or any change of any supplements or diet, okay, they need to know, be aware that there is a risk of the INR to change, okay? And that sometimes that may require change in the dose, okay, of the warfarin. So monitoring, more regular or frequent monitoring may be required, okay, if dose adjustment is done, okay. You also need to counsel them to recognize how, what are the symptoms of bleeding and thrombosis. The bleeding, like if they have GI bleeding, they can have black tarry stools or fresh blood in the stool, okay. So they may have bleeding in the urine or more heavy menstrual bleeding, for example, okay. So thrombosis, they may have a new stroke or new swelling or sudden shortness of breath, depending on the site of thrombosis, okay. And when such symptoms occur, you should counsel them that they should be aware of it, and the family should also be aware of it. These are the symptoms, and they should be sent immediately to the emergency. And the patient should also know the importance of compliance with warfarin, because if they are not compliant, they may be subtherapeutic, so that defeat the purpose of warfarin. So they are at risk of thrombosis, and they also need to go for their INR clinic appointment and follow up to monitor their INR to ensure that they are within the targeted range, okay, and the proper documentation of the INR, so that we can see the trend as well as adjustment is easier, okay. So they should always bring the INR booklet, and they should also be informed that they need to tell doctor if any special situation occur. For example, if there's any changes in their medication, for example, new antibiotics, okay, if they're suddenly acutely unwell with fever, or they plan for invasive procedures or surgery, or suddenly they have an accident or trauma, or if they're pregnant, or suddenly they or they plan for pregnancy, so they need to inform, okay. And they also need to know what should they do if they miss their dose, okay. We'll go into that as well. And what are the lifestyle modification that they may be required, especially if heavy sports, like contact sports, they need to avoid, especially if it's a contact sports that risk of injury, okay. And precautions they need to take, for example, fall precaution, especially in elderly. All right. So and also with the use of any sharps tools, they need to be cautious to avoid a risk of cutting or injuring themselves. Okay, so this will help to reduce the bleeding risk. This is regardless of any anticoagulant, whether they're warfarin or even DOAX. Okay, so we go into the benefits versus risk of warfarin. So the benefit, you can counsel the patient. The aim is clot prevention, okay, which can be primary, meaning that they have not had a clot, but it's to prevent a clot because they're at high risk of clots. Okay, example, the patient with atrial fibrillation. Okay, so or secondary, they already had a thrombosis, so you don't want to get another thrombosis. So it's a secondary prevention. All right, and this is important because getting all these thrombosis complication, they can actually be affecting their quality of life as well. So what else? Other benefits is that this warfarin, they are very cheap and they're very widely available in any pharmacy as well. And in certain situations, especially for prosthetic heart valve and antiphospholipid, they are greater efficacy compared to other anticoagulants. Okay, and the reversal agent for this drug is also cheap and widely available, like vitamin K and the FFP. They are cheaper and more available in the district setting. Okay, so the disadvantage or some of the risks, the disadvantage would be mainly the warfarin has narrow therapeutic index. The therapeutic range is only 2.0 to 3.0, but this is the general range, but at some condition they may be a bit higher. So because of this narrow therapeutic range, we need to ensure that their INR is monitored regularly, okay, and that will actually help us to know whether the warfarin is effective in preventing the thrombosis as well as the bleeding risk. Because if they are subtherapeutic INR, they are at risk of thrombosis. Okay, if they are supratherapeutic, they are at risk of bleeding. Okay, so like any other anticoagulants, the serious complication of warfarin is bleeding. Okay, and they are also, the disadvantage is that they have a lot of interactions with drugs, okay, medications, as well as any other over-the-counter drugs, as well as foods. Okay, so other adverse, the bleeding is the most common. Okay, usually the risk is about 1%. Okay, especially during the first year of long-term warfarin, up to 8%. Okay, and they can occur at any INR value. Even normal or subtherapeutic INR patient can also bleed. A normal patient without warfarin also can have bleeding. So it can occur at any INR value. And the risk is, of course, higher when the INR value is above 5. Okay? And they are also additive. The risk is additive and is related to the intensity of the anticoagulation, okay? The use of any concurrent medication that can interact with the warfarin, as well as the patient's clinical condition. So these are the patient's clinical condition that can increase the risk of bleeding while the patient is on therapy. Elderly, especially age above 65, if they have concomitant cardiac disease like ischemic heart, hypertension which is uncontrolled, or underlying gastrointestinal disease like peptic ulcer or history of GI bleeding, liver insufficiency, because the liver is important for metabolism of warfarin, as well as any liver insufficiency can also be associated with coagulopathy. Okay, so if they have any other concomitant bleed hematology disorder that can affect their hemostasis, like thrombocytopenia, platelet dysfunction, or any coagulation defect, they are also at risk of bleeding. Similarly, if they have underlying cancer, they can also be at risk, because cancer, they may have bleeding from the malignant lesion, malignant tumor, or the immunosuppressive, the chemotherapy agents can also cause cytopenias, especially thrombocytopenia, okay, as well as platelet dysfunction. So that can also increase the risk of warfarin. And furthermore, there may be also interactions, a lot of drug interactions. Okay. So patients with strokes, dementia, cognitive impairment, or psychological impairment, they are also at higher risk. Okay, so use of concomitant use of drugs like NSAIDs, okay, or aspirin, okay, they can also be at higher risk. Okay, others like recent trauma, surgery, or excessive alcohol intake, or binge alcohol drinking, okay, or procedures like intramuscular injection, okay, will actually leads to a higher risk of bleeding. Okay, so these are the one in the red box are those that we cannot modify. So the one in green is the one that is a modifiable risk, okay, in which you can try to avoid if possible. Right. So bleeding risk can also be measured, okay, with some of the bleeding scores here, but we won't go into that detail. Basically, all these scores, the content has been covered in the earlier slides, but just to let you know there are scoring systems to calculate the risk. Okay. Other adverse effects include skin necrosis or purple toe syndrome. So usually this occur at the 3rd day to 8th day of the treatment, and it's because of the protein C or protein S deficiency. And it usually happens when you load with a high dose of warfarin, okay, and you can prevent it by bridging it with heparin, okay. This is how the skin necrosis, okay, is usually painful, okay. So other less serious side effect includes alopecia, osteoporosis, rash, and also GI symptoms. Okay, so baseline testing before warfarin, we should include full blood count to look for anemia and thrombocytopenia, as well as baseline coagulation to know whether they have underlying coagulopathy. Okay, and also to know whether they have underlying concomitant renal impairment as well as liver impairment. Okay, that will increase the risk of bleeding. And for childbearing women, childbearing age, so they should have a urine pregnancy test to make sure that they are not pregnant when we are going to start them on warfarin. So what are the target range? So generally there is 2 to 3, all right? And you should achieve the target strictly if they have valve replacement or they have acute or recent venous thromboembolism. Okay, and you can be a little bit lower or outside the target range, especially for other cases, like for example, chronic atrial fibrillation. You don't have to be so strictly 2.0 to 3.0, 1.8 is acceptable. All right, so here are the list of conditions and their target range. Okay, so you can see majority are within 2 to 3, but there are certain conditions like those with recurrent VTE, while they are still being anticoagulated and within therapeutic range, they may require higher INR target, 3.0 to 4.0. Similarly, those with a high risk mechanical valve, in which they have aortic valve or mitral valve both replaced, okay, and they have additional risk factor of thrombosis, so they have a little bit higher target, right? So for warfarin administration, I'm sure all of you are familiar. Usually it's taken by oral, okay, and the dose is variable for every patient. So there's no fixed dose, okay, and we have to adjust according to the INR target, right? And the frequency is once daily, okay. It has to be taken at the same time each day, okay, and can be taken before or after meal, all right. So the duration is not fixed. It can be depends on the underlying diagnosis as well, all right. If it's VTE, it can be 3 to 6 months, and extended or indefinite depend on the risk factor. But for atrial fibrillation, chronic AF usually is indefinite. Okay. So to monitor warfarin, okay, it depends on the patients whether they have depends on the phase. Okay, so for initial phase, we would need to know whether they have acute or ongoing thrombosis or not. Okay, if they have acute or ongoing thrombosis, okay, then you need bridging with low molecular weight heparin or heparin. Okay, if they do not have any active thrombosis, so it's for prophylaxis measure, we just use warfarin only. Okay, and the daily dose for the initial 7 days, okay, for the initial 7 days, usually it depends on the patient, whether they are the sensitive type or non-sensitive type. Usually, in the sensitive type are those who are elderly, okay, or those with at higher risk of bleeding. Okay, so they are sensitive. So we should start them at lower dose, 3 mg on the first day, followed by 2nd mg on the 2nd day and 3rd day. All right. For the non-sensitive, so they are not at high risk of bleeding. And they are not elderly age group. Okay, so we can start them at a normal dose of 5 mg. Okay, then 5 mg, then cut down to 3 mg. So on day 3, we should start to check the INR. Okay, so then we can from there we can adjust the dose accordingly, and subsequently the next monitoring can be either daily or every alternate day. Okay, so depends on the INR, and you should remember, if for those with active thrombosis or ongoing thrombosis, who are on bridging therapy, the bridging therapy should be stopped once the INR is 2 or above, within the therapeutic range. Okay, so subsequently at the day 8 after 1 week, okay, so the range, the adjustment would depends on the range as shown here. Okay, so for maintenance phase, usually this starts once the INR target has been achieved and is at consistently within the target. All right. So when they are within the target consistently, you can actually increase the level of interval of the follow-up from from every alternate day to once a week or twice, once a week or 2 weeks interval. Okay. All right. And subsequently, if they are still stable, you can also increase to every 4 weeks and then 6 weeks to 12 weeks. Okay, but at times while they are on maintenance, sometimes the target, the INR may be not within the target, so you should readjust the follow-up again, monitoring accordingly once you adjust the dose. Okay, so especially if they're more, the target is high but less than 5, you should consider withhold or adjust the dose and then recheck it within a week. Okay, so the maintenance dose can be affected by a number of factors. Okay, so that would depends on the underlying diagnosis, and how sensitive the patient are to the warfarin. So everyone will have different dose. Okay, especially elderly, they're very sensitive. Okay, and the patients, whether they're compliant or not. Okay, and drugs, whether they are consuming any other medication that can interact, the body mass index, alcohol consumption, whether they're taking it chronically constant or whether they're taking it in a binge. Okay, and nutritional status as well, even chronic smoking. Okay, and certain race also they may require different dosing. Like Indian ethnicity, we notice that they usually require higher dose of warfarin to maintain the same target, right? So for dose adjustment, so we should consider when the trend is 2 consecutive reading of INR is subtherapeutic or supratherapeutic, despite the previous control is good. Okay, and also when the patient just started anticoagulant, so usually we will need some adjustment of the dose. Okay, and lastly, when there is interaction of the warfarin with any drugs, supplements, herbal diet. Okay, so you should consider if the patient's range is very different, markedly different from the usual. Okay, you should consider rechecking the INR the same day or at least the next day. Okay, to make sure that it's not due to the lab error. Okay. So for warfarin dose, we can calculate. There is a simple method to calculate. So it should be calculated based on the weekly dosing. Okay, and the dose can be increased or decreased up to 15% of the weekly dosing. Okay, so usually if we increase by 15%, that would roughly correspond to about the increase of INR of 1. Okay, but for simplicity, we use 1% increase of warfarin dose correspond to increase of 0.1 of the INR level. Okay, so I will give you, so the maximum change of the daily dose is 1 mg. So because the tablet, the lowest dose is 1 mg, so the minimum change is, if you want to increase, is by 0.5 mg. Okay, so 0.5 to 1 mg. You cannot be in between, like 0.4, 0.6 cannot, right? It has to be either 0.5 or 1. Okay, for example, okay, here I'm just giving you a simple example. Okay, so you have a patient with a target INR to achieve, which is 2.0 to 3.0, and the patient's current INR is 1.3. Okay, so the patient still need another 0.7 to achieve the target, right? So, and the current patient's current warfarin dose is 3 mg, in which the patient is currently taking from Monday to Sunday every day. All right, so how would you calculate the dose? All right, so from here, the 3 mg, you can calculate the weekly dose is 3 times 7, which is equals to 21 mg. So remember, 1% of the weekly dose adjustment can change the INR by 0.1. So here we need to increase by 0.7 INR. So that means we need 7% increase of the dose from the baseline, 21 mg. Therefore, that if you calculate 7% from the 21 mg is equivalent to 1.47 milligram per week. So you can round up to 1.5 mg per week. Okay, so 1.5 mg per week, how are you going to adjust the daily regime? So here you can change. Okay, there are two methods. Either you can ask the patient to increase by 0.5 mg over the weekends, Friday, Saturday, Sunday, or take it on alternate days, increase by 3 days. Okay, 0.5 mg increase in the 3 days. So what happens if patient miss dose? Okay, so the patient should know that they should take it as soon as they remember. Okay, if it's still within 8 hours from the usual timing. Okay, but if it's more than 8 hours or is nearing the time of the next dose, so they can just omit that and take the dose at a usual time of the day. Okay, and they should not double up the dose to catch up. All right. And when they miss the dose, they should also record it and inform the doctor at the next appointment. So then you know why the INR may be subtherapeutic. Okay. So when they are outside the therapeutic level, so what should you do? Okay, for subtherapeutic, you should ask whether there's any thrombotic symptoms. Okay, you should explore any thrombotic events occurring as a complication, and you should explore what are the risk factors for them to be subtherapeutic. Are they compliant? Did they miss their medication? Okay, and whether they have there's change in the diet, or they take some new foods, or they have any changes in the medication, either add in or removing the usual medication, or whether they take the wrong dose by accident. Okay, so in such cases, you should consider increase in the warfarin dose, as how we have done earlier discussion. If it's supratherapeutic, okay, patients are above the target range, so you should explore whether they have any bleeding symptoms. Okay, then ask what are the risk factors. Okay, do they have any new comorbids or any intercurrent illness at that point of time, and whether they are compliant to the medication. Okay, they may be compliant, but sometimes they may be taking the wrong dose. Well, sometimes they may be intentionally taking overdose due to whatever reason. Okay, and sometimes they also may have risk of drugs interaction or food interaction that can increase the INR. So for patients, if they have large variation of their diet, their vitamin K intake from their food, that can also lead to supratherapeutic INR as well. Okay. So here in this condition, you should consider stopping the warfarin depending on the INR level. If it's too high, especially more than 5, okay, and you may consider reversal agents, okay, depending whether there is also any presence of bleeding and how high the INR level. Okay, and once there is no bleeding or the INR has achieved therapeutic range, you should restart the warfarin at a lower dose. Okay. So just to go into detail, for those with supratherapeutic INR, so if they have life-threatening or serious bleeding, you should send the patient into emergency department immediately. Okay, the warfarin should be stopped. They can be given empirical vitamin K up to 10 mg intravenously. Okay, even without waiting for the result, because if you want to give other agents, reversal agent, it may take a while to get ready. Even the fresh frozen plasma. Okay, four factor PCC may not be widely available, especially in the district hospital. Okay, so the most common if you have is FFP in the district setting. Okay, so here you should also consider use of fibrinolytic agent like tranexamic acid if there is any oral or mucosal bleeding, but not for any urinary tract bleeding. Okay. So if the patient have a massive bleeding, you may also consider supportive transfusion if indicated. All right. So if the patient have a supratherapeutic INR but need to undergo urgent surgery or procedure, so the management would depend on how urgent is the procedure, as well as the bleeding risk from the procedure, as well as how fast the reversal of the warfarin is required. Okay, so usually in this case, you just stop the warfarin, but to use the reversal agent or not, that will depend on how soon the surgery is, whether they can wait up to 24 hours or not. If they can wait, you can consider the use of vitamin K. Okay, so you should consider should consult with the surgeon or interventionist to decide on that. Okay. All right. For those patients who do not have bleeding, but the INR is above 10, you should withhold the warfarin. Okay. And also can consider vitamin K oral if need. Okay, and they can be repeated if needed. So vitamin K usually is oral, is not a tablet form. You can actually use the intravenous bottle vitamin K, but use it as oral solution. All right. And the INR should be monitored daily or every alternate day, depend on how fast the trend drops. Okay. And if the INR is between 4.5 to 10, you should also withhold the warfarin. And vitamin K is optional, depends on whether the patient is at the type who are at higher risk of bleeding. Okay, if they're at high risk, like elderly, you may consider a low dose, like 1 to 2.5 mg. Again, they should have very frequent INR monitoring. And in this group, the patient should restart the warfarin at a lower maintenance dose once they achieve therapeutic range. Okay, so for elective procedure, okay, if they need reversal of warfarin, you should plan it ahead 3 to 5 days before the surgery. And depending on the INR level before that, okay, if your INR is between 2 to 2.5, you should stop 3 days. If it's almost 3.5, should stop 4 days before the surgery. Okay, so the target pre-op INR should be about 1.5, okay, or lower. And the INR should be checked just before the surgery, just to make sure that is adequate hemostatic function. Okay? And also 24 hours after surgery, if there's no bleeding risk, okay, you should resume the warfarin. So the bleeding risk would post-operatively would depends on the surgeon to decide. Okay. And the use of heparin, low molecular weight heparin pre-operatively also should be considered, depending on the risk of surgery and the risk of thrombotic from the surgery, as well as how long the patient has to come off from the warfarin. Because the OT time, the operation theater time, is sometimes unpredictable. So sometimes there may be a delay. So you may need to consider the coverage using this heparin. Okay. Just to go through some of the contents in food that are high in vitamin K. So I'm sure all of you know that any green leafy veggie, but green tea are also high in vitamin K. Okay? They should be used. They should be used in the restriction. Soybean as well. Okay, so green leafy veggie, seaweeds. All right. And for drug interactions, okay, if there is potential drug interaction, the patient should have INR check 3 days after the medication is changed. Okay, so for amiodarone, the warfarin should be reduced by 1/3 or half empirically. Okay, then you check the INR again on day 3, and then the dose should be adjusted again accordingly. Okay? So here are the whole length of list of medication. I won't go through them, but you can have a look later once the slide is given. Okay. So when you should consider DOX, so DOX you may consider especially when the patient are not keen for regular monitoring, okay, or they do not want to have restriction in their diet. But the advantage is that compared to warfarin, the bleeding risk is lower, okay, and they can be used when the patient is really difficult to control their INR, very labile INR. But they should not be used if the patient have underlying mechanical heart valve or they're pregnant, okay, pregnant any trimester, they should not be used, or if they have underlying antiphospholipid syndrome, or they are the one with very poor adherence, they should not be used, because the DOX, they only act depends on whether they are OD or BD dosing. It can be the they are only therapeutic within that time. So if they miss their dose, they are already at high risk of thrombosis. So they need to have strict adherence, especially when they have when they are on DOACs, in order to have the benefits. Okay, so in summary, warfarin is a cheap and effective oral anticoagulant, but because of the narrow therapeutic index, various drug interaction, so you need close monitoring to reduce the bleeding tendency. Okay. All right. Any questions? I'll be happy to take if any.
Thank you, Dr. Diana, for your enlightening talk. Due to time constraint, I think we shall encourage the participant to post your question at the chat box, and Dr. Diana will answer your questions.